Hello, everyone. Thank you for joining us today for our webinar entitled Botulinum Toxin in Movement Disorders. My name is Dee Tran. I'm Communications Editor for the International Association of Parkinsonism and Related Disorders, and I will be moderating today on behalf of IAPRD. First, I would like to thank our sponsors, Ipsen and Merz, for their generous support in making this webinar series possible. Today is part of a whole series of botulinum toxin lectures. We hope that you will be able to join us in the future as well. Today's webinars consist of two 20-minute presentations to be followed with 5 minutes of questions and answer in between. So please type in your questions in the chat box at any time. Also, you would help us serve you better by filling out a brief evaluation form after the webinar. This webinar will be recorded and available on demand for 1 year at our website, www.iaprd.org. And now I would like to introduce to you to Dr. Zizad Ayub and Earl Lim. Dr. Ayub is a clinical professor of medicine at David Geffen School of Medicine at UCLA and clinical professor of PM&R at Western University of Health Sciences. He is director of the UCLA Multi-Campus PM&R Residency Training Program at RLA and RC. He is a fellow of AAPMR and affiliate member of AAP. He's board certified in PM&R, SCI medicine, and BI medicine. And he's also specialized in pain management and addiction medicine. And he has special interest in spasticity management for the past 25 years. He is the director of the spasticity management program at RLA and RC and has been a principal investigator on multi-center grant-funded research clinical trials on spasticity and other areas. And also Dr. Lim is provost for teaching innovation and quality at the National University of Singapore and senior consultant neurologist at the National University Hospital. He trained in neurology at the Singapore General Hospital, after which he completed his training in movement disorders at the Mount Sinai School of Medicine, New York, under Professor C. Warren Olanow and Mitchell F. Prin. His interests are in movement disorders, particularly the treatment of Parkinson's disease and the accurate injection of botulinum toxin for various neurological conditions. And with that, now I would like to welcome first Dr. Ayub. Dr. Ayub.
Thank you, Dee Tran. I would like to thank the International Association on Parkinsonism and Related Disorders for the opportunity and honor to speak with you today via this webinar from Los Angeles, California, where the local time is 6 p.m. March 11. And just let me do check, Dee Tran, can you see the slide? Okay. Dee Tran, can you see the slides?
No, we can't see your slides yet, Dr. Ayub.
I think it's from your end. How about now? Can you see them?
Perfect, looks good.
Okay.
Yes.
So again, let's start over. Thank you for the International Association of Parkinsonism and Related Disorders for the opportunity to speak on this webinar. I am in Los Angeles and the local time here 6 p.m. and it's still Thursday. I know in some areas like in Singapore now Friday morning. As you said, Dee Tran, I have a special interest in spasticity. This morning I had a clinic where we had actually 15 patients scheduled this morning from 8 a.m. to 12 p.m. and we treated about 14 out of the 15. So, I cannot move my slides now. Sorry. All right. So these are the things I would like to cover. I hope to cover today. One, the guidance technique, advantages and limitation of each technique, and review the level of evidence on these techniques, and also give some examples how we localize some of the commonly injected muscles. Physician utilize one or more of localization techniques to guide botulinum toxins. These techniques include manual needle placement, EMG, E-stim, image-based guidance such as fluoroscopy, CT scan, MRI, ultrasound, and combination technique can be used as well. Now, we use anatomical guidance to identify muscle location, the site for needle insertion based on landmarks, palpation, passive range of motion, active range of motion. This technique, usually we learn it from anatomic guides from gross anatomy that we learned in residency or medical school. Of course, to do this, you need injection supplies. The next technique is EMG, which provides auditory and or visual feedback of muscle activity. It may help identify muscles contributing to the posture and also to identify the level of muscle activity. It may be more useful in patients with focal dystonias than those with spasticity or dystonia associated with upper motor neuron syndrome. It can, of course, assess in motor point localization. For that purpose, you need portable equipment now available, different brands and or the typical EMG equipment. Of course, you will need the injection supplies, including insulated needles to do the EMG and the injection. Electrical stimulation provide visible feedback of muscle contraction in target muscles, may be more useful than EMG in patients with upper motor neuron syndromes. E-stims can assist with motor point localization and also require the use of portable equipment, stimulators, and injection supplies like EMG. Ultrasound provides precise localization of muscle position, depth, the size of muscle, the presence of hypertrophy or atrophy in the muscle, visualization of the needle, and also good, effective, help you avoid high-risk structures during performing the procedures, such as vessels, nerves, and targeted muscles. Of course, you will visualize the needle, and also not only that, the injectate while during the injection, you can visualize that as being injected in the muscle. You need ultrasound machine, transducers of various frequency, of course, good knowledge and training in the physics, instrumentation of ultrasound, etc., and injection supplies. Now, when using ultrasound guidance, muscles, glands, nerves, and tendons are identified and distinguished from one another based on their sonoacoustic properties. Individual muscles are further identified by using pattern recognition on ultrasound. Muscles may look different on ultrasound, and including contour lines and also the recognition of adjacent structures. And this is typically done in transverse scanning mode. Passive and active range of motion may help identify muscles and individual muscle fascicles when you do the injection. Now, there is a couple technique we use to insert the needle in the muscle, one out of plane, the other one in plane technique. The out of plane technique, the needle is inserted across the short axis of the transducer. When you use this technique, the needle is seen as hypercoic dot. On the other hand, in plain technique, the needle is inserted along the length of the transducer. With this technique, the whole needle is seen. However, this technique can be challenging to do. You need to keep the needle within the narrow beam of ultrasound, which is really as thin as your credit card, perhaps. Now, and if you insert the needle too steep or with oblique angle, the visualization of needle may be lost due to the needle anisotropy on ultrasound. Now, other imaging technique can be used, such as fluoroscopy, which is helpful actually to identify some structures, but not targets, muscle targets. CT scan and MRI has been used also to identify many muscles. Now, combination of technique can be used, EMG with ultrasound, EMG with E-stim, or ultrasound with E-stim. These techniques precisely can locate the target and also are helpful in muscle activity identification and also motor point focalization. Now, which technique we select? There are a number of factors that may influence the clinician choice of guidance for botulinum toxin injection. One is the clinician's training and expertise, the availability of equipment, the advantages, limitation of given technique, the target for injection. Some technique may be more useful in some target muscles than others. Of course, also there are patient-related factors depending on patient condition, cooperation, the presence of deformity, and contracture, etc. The key is to recognize the potential advantages and limitation of each of the possible technique when you do your injection. Now, let's review the literature and the level of evidence on guidance. A systemic review was published in 2017 by Chan and Associate. They looked at the impact of injection technique on outcome for botulinum toxin injection for limb spasticity. The authors reviewed 597 studies, only 9 studies of which met the inclusion criteria. One of them to be randomized clinical trials. And only 5 of the 9 studies were powered for statistical significance. So based on the review, the author concluded that instrumented guidance are superior to manual needle placement, regardless which guidance you use. Also, they concluded additional studies are needed to evaluate functional outcome with the various guidance technique. Now, there were additional conclusions of this review, not necessarily relevant to guidance. We're not going to go over that. One of these studies were included in the review, a study by Blomus, who studied the effectiveness of botulinum toxins injection with and without EMG guidance in patients with hemiplegia related to stroke. He had a randomized clinical trial of 27 patients included. 15 subjects where muscle were identified by EMG and another 12 subjects without EMG. So he concluded based on this, in this study, Blomus and his associate, the effectiveness of injection is superior when it is performed with EMG rather than without EMG. Similar studies by Satamato, which is a small study of 15 stroke patients, they looked at the injection of botulinum toxin for spasticity in the wrist and finger flexors using ultrasound guidance for placement versus manual needle placement. And again, based on that, they concluded ultrasound guidance could improve clinical outcome measures better than manual needle placement in post-stroke patient with spasticity. Now, another studies, a couple of studies actually by Preselli. The first one was a study that examined the accuracy of toxin injection into the gastric muscles, medial head and lateral head, in adult with spastic equinus using manual needle placement or e-stim confirmed by ultrasound. And they found the accuracy of localization of the medial head is 92% versus 79% for the lateral head. So lateral head was harder to be accurate when you localize that. So in his second study, which was randomized clinical trial of 60 subjects, and they use outcome measures such as modified Ashworth scale, the Terdu scale, they concluded instrumental guidance may improve the outcome of botulinum toxin into the spastic forearm muscles of stroke patient compared with manual needle placement. There was no difference in outcomes between e-stim and ultrasound in upper extremity injection for these subjects in this trial. Now, another systemic review conducted by Gregau reviewed 10 studies, only 7 were randomized, and they looked at the guidance of botulinum toxin in children and adults for spasmodic torticollis and also for spasticity. They concluded that instrumented guidance of toxin is more effective than manual needle placement. There was no specific recommendation that can be made based on this systemic review regarding the choice of the instrumented guiding technique. One study maybe of interest to some, Bayon Matu looked at 107 children, 60 were injected under ultrasound, 47 by e-stim. He concluded that the group of patients that injected with e-stim guidance had a little bit more pain during the procedure than the ultrasound guided group. Now, another study by Chen and colleagues evaluated the accuracy of manual needle insertion. Subsequently, after the needle was inserted, it was checked by e-stim or ultrasound for upper and lower limb spasticity. In children with CP, the number of subjects in this trial was 226, and they evaluated more than 1,300 injections. They reported that the manual needle placement was accurate in the gastric soleus only in 75% of the time. In the hip adductor lower, 67, medial hamstring, 46% of the time, tibialis posterior, 11% of the time, biceps, 62, in the forearm and hand muscle is somewhere between 13 and 35%. So another study by Yang and his colleague, it was a prospective study in 39 children, and they evaluated the accuracy of needle placement in 272 injections, similar to the previous studies. So the needle placement manually was accurate only in 92% of the time in the medial gastric. However, the lateral gastric, it was in 57% of times in young children. However, in the whole group, 64.7%. So other consensus statements, paper published that came from Europe, and our colleagues from Europe state that injection guidance was recommended for deep muscles or where anatomical landmarks were difficult to determine. Another statement reads, manual guidance alone might be sufficient for some superficial muscles. However, supplemental guidance with either EMG or ultrasound was required for deeper muscles. Now, in conclusion, when you look at the level of evidence, guidance is superior to manual needle placement. Guidance, whether it's ultrasound, EMG, or E-stim. However, head-to-head trials with larger number of subjects is needed to determine which technique is superior to others when used alone. Additionally, we may need studies to determine the value and the use of combination technique for botulinum toxin injections in both upper limb, lower limb, adult, and children. Now, we're gonna, the last portion of this presentation, go to the muscle localization. Let's review the most common postures with spasticity. As you see on this slide, for the upper limb spasticity, commonly you see a deduction of the shoulder with internal rotation, elbow flexion with pronation, wrist finger flexion. That's not the only pattern you see, but one of the common ones. For the lower limb, you see flexion of the ankle, flexion of the toes. So we're going to review, just because these are the most commonly injected muscles, how we localize these muscles. For the biceps, the anterior surface of mid-arm, I usually do 4 injection sites in the muscle. Sometimes, believe it or not, can be difficult to localize this muscle, even using nerve stimulation. You have to go multiple times to get it. Again, this is the exception rather than the rule, based on patient characteristics. Sometimes really can be challenging to find even obvious muscle like that. For flexor carpi radialis, if you take a 3-4 finger breath down from a line connecting the medial epicondyle and biceps tendon, as shown in this slide, you should hit the flexor carpi radialis. For flexor carpi ulnaris, if you take 2 finger breath volar to the ulnar at the junction of the upper and middle third of forearm, just underneath the skin, once you pass the tip of the needle, you should be in this muscle most of the time. For flexor digitorum superficialis, if you hold the patient arm as it is shown in the slide, and you have your index finger pointing to the attachment of biceps tendon, you go just ulnar to the tip of the index finger, you should hit flexor digitorum superficialis. Flexor digitorum profundus, I like to hold the arm like shown in the slide. If you place the tip of your little finger on the acromion and the ring middle index finger along the shaft of ulna, and just you introduce your needle parallel to the ulna at the tip of your index finger, you will hit that muscle. You go deeper, you will get the median portion of the muscle, or the portion supplied by median nerve, and more superficial, the other portion supplied by ulnar nerve. For flexor pollicis longus, if you take one hand breath from the wrist grease and you go volar to the radius, you should hit flexor digitorum longus. You don't want to go too medial or too ulnar, because your radial artery passes through that neighborhood. For adductor pollicis, usually I inject that from the top down, from the dorsum of hand, rather than the palm, because it's less painful and probably cleaner. So you just aim to the proximal end of the first metacarpal bone, you should hit that. For the lower limb, if you want to localize the gastric, you take one hand breath below the popliteal crease. If you put the needle on the medial mass, you will hit the medial head. On the lateral mass, you will hit the lateral head. And by the way, this is really very superficial, and no wonder in these clinical trials, this lateral head was missed a lot. People think this big mass is gastric. It's more actually soleus muscle. The gastric muscle is a thin, relatively thin muscle. The soleus muscle, you localize this muscle just distal to the belly of the gastric muscle, medial and anterior to the Achilles tendon. For tibialis posterior, if you take one hand breath distal to the tibial tuberosity and one finger breath of the medial edge of the tibia, you will hit that. A lot of times you would go through the flexor digitorum longus as you do that. So the flexor digitorum longus, the medial edge of the tibia at the mid shaft, in that point you insert your needle, and if you go deeper from the same point, quite often you will hit tibialis posterior. A lot of times I don't have to make two separate needle insertions to hit these muscles. Flexor hallucis longus, 5 finger breath above the insertion of Achilles tendon and anterior to the medial border of the tendon toward the tibia. And that concludes my presentation, and happy to take questions. Are we taking questions now, Fran?
Yes, thank you so much for your presentation, Dr. Ayub. And this one question, and that question is, which is the best choice for using methods to inject the BT into the patient?
Which the best method?
Mhm.
Again,
Which is the best choice for using methods to inject the BT, the patient?
Okay, is that tibialis posterior? Okay, so I you know, again, I use all these methods. For most muscles, I'm happy with using electrical stimulation. I see a value of each technique. I think of it as a toolbox. You have different tools, and you have this nail, you want to drive a nail in the drywall. So you can use any one of these tools to do it. And again, this is really based on your comfort level, your experience and expertise. But to me, I like to really get that muscle contraction, which is to me a very good confirmation where I should inject my medication. So, but I see the value of ultrasound for isolated muscles. Some muscles is to do like one of these muscles that we inject, iliopsoas muscle. I mean, I can see a great value advantage to use ultrasound in muscles like that.
Okay. This seems to be the only question. So maybe we can go on to Dr. Lim now, and then we'll circle back at the end and see if there are any more questions. Thank you, Dr. Ayub.
Thank you. I'll be standby.
Dr.
Hi, everyone. So I'd like to thank the organizers for inviting me to speak at this webinar. And I thought I would just start off with my declarations. There's nothing there's nothing controversial there, but anyway. So this is the outline of my talk. I start off with what makes injecting patients with spasticity different from injecting other kinds of patients, for example, dystonics. And then I'll go on to what we must do before the injection, how we inject the patients. And although Dr. Ayub has already done a very thorough and good job, I thought I would just talk about practical aspects to this point. So which muscles to inject, which technique, special considerations, and I call these patients the bosses because they are the ones who have to live with the disease and the consequences of the action. So they play a large part in discussing what muscles, how much botulinum toxin, etc., and then what to do after the injection. So what makes injecting patients with botulinum toxin different is that, with dystonia, which is the other thing where we always talk about injecting botulinum toxin, the muscles are actually otherwise normal. It is the central nervous system that drives the abnormal posturing. So it's quite easy to inject them. And what you need to do is just assess which muscles to inject and not overly inject. On the other hand, with spasticity, it's a lot more difficult, I feel, because not only you don't have the normal muscle function to help you to achieve normality. And in fact, there's often a lot of weakness. So what you have with botulinum toxin and spasticity is that you may help the patient, but often because of inherent weakness after the disease, you might still have inadequate or imperfect Botox or botulinum toxin injection results. So don't forget that dystonia is primary or secondary. There's no weakness. You aim to weaken the overactive muscles, and contractures almost never occur unless it is through prolonged abnormal posturing. Whereas with spasticity, it's always secondary to CNS dysfunction. There's always weakness, or at least there's usually some form of weakness, and you help to weaken the overactive co-contracting muscles. But you also don't forget that they are irretrievably weak muscles, and contractures are more common, especially when it is a patient with very great weakness who has recovered a decent amount of function. But the fact that there is disuse atrophy also can complicate dystonia. So what do you do before the injection? Well, so I cook on weekends with my family, and one of the things that I've learned as I watch cooking shows is the concept of mise en place, right? You prepare all the things beforehand so that when you finally cook, especially in Asian cooking, you just throw everything together and you can get a decent meal. So it is with botulinum toxin injections. Always ensure that everything is ready. You have a clean surface, you have anything that needs to be done, you've already prepared beforehand, because there's nothing more horrible than a messy desk, a messy lot of notes, and you end up injecting the wrong thing to the wrong patient. The other alternative is that you get pricked by a needle that's left behind. So everything in its place, and always keep the surface properly. I do have nurses to assist me when I do my injections, but I do my own dilutions, etc. Because the last thing I want during my injection schedules is to have to worry that someone has made a mistake. So I'm a bit OCD, and that's my way of practicing. But you decide what works best for you. Don't be afraid to use an atlas during your injection. I mean, we can't remember everything, and even surgeons revise the night before for complicated surgery. So you have both the EMG guides, and I noticed Dr. Ayub also uses Pareto, which is like my Bible. But there are other atlases that are useful. For example, the Atlas of Ultrasound Anatomy, and there's Karen Alter's book and the Bradley O'Donnell book. And also there's apps that you can get on your iPad, such as iMuscle, and they have it for the neck and head. They also have it for the body. And I find these almost invaluable. Practical things that we don't normally write about in books. Don't forget that needles are of different gauges and different lengths. If you're trying to withdraw botulinum toxin from the bottle, because you go through a rubber bung, don't forget that with each time you go in, you're actually destroying your sharpness of the needle. And so what I do is I actually change the needle for the injection. So let's say if it's hemifacial spasm. On the other hand, when you're talking about something like botulinum toxin for spasticity, as is the case here, you have other kinds of needles you need to think about. But the worst thing you can do is use a short needle that does not reach the targeted muscle. So always think about these things when you're doing your injections. And in fact, I even have sessions where I will have different syringes with different lengths of needle, and I actually label them according to what muscle I'm planning to inject. Because there's nothing worse than being caught out and suddenly you have to look at the patient and say, I'm sorry, I have to inject you again. This is something that has bugged me when I do demos abroad, because sometimes I don't check this and then I get the wrong needle, the wrong syringe. So for example, for hemifacial spasm injections, when I go abroad, sometimes they give me the insulin syringe, which you see at the top, and the needle is not, it's a permanent needle. You can't even exchange it. So each time you put the needle through the bung, you're actually blunting the needle. And what I dislike about the insulin syringe is that it is in units of 0.2, but you don't always use a 0.2 injection when you're doing injections in hemifacials. So I would just tell you that for practical reasons, always decide what kind of syringe you want to use and make sure that you get a good fit for the patient's needs. Uh, when I first came back from America, we did not have the concentric monopolar EMG needles, and it took some time for me to be able to get it. So in fact, for the first 6 months, whilst I was trying to source for a good supplier, etc., and go through all the processes in the hospital, I had to jerry-rig a normal EMG needle, but I knew that it would be less than accurate because even if you're targeting the right muscle with your EMG needle, your next needle that goes through is not going to be in the same location. So remember that if you're doing EMG for any EMG guided injections, you want a concentric monopolar needle, not the bipolar needle, which we have for EMGs, because those are solid needles. This is an important point, and there's no substitute for that. You cannot jerry-rig an injection using some other kind of needle. Dilution should be with normal saline. Do not use local anesthetic to dilute because you might be changing the nature of the botulinum toxin. The pH will be different, etc. There are different qualities. So use normal saline to do your dilution. Besides which, if you do repeated injection, you do not know what happens with the local anesthetic because there was a study that showed that local anesthetic can cause oxidative stress within cells. So you don't know what happens when you do a local anesthetic botulinum injection. The picture of the bartender reminds me to tell you not to shake the bottle. Some people just use a tiny needle, a narrow gauge needle. So the number is, let's say, 28 or 29. And when you put the needles through your bottle of botulinum toxin when you're diluting, it comes out in a spray and you get lots of bubbles, and it's very hard to clear the bottle in time to run your clinic efficiently. But shaking it can denature the protein, so do not shake. Just, they call it, you can just do a slow roll of the bottle. I just put it between my hands and I roll the bottle slowly. Always, when you're doing your injection, look for flashback because botulinum toxin is first and foremost a toxin. Do not presume that it is safe to just inject a patient with botulinum toxin into a vein. So always look for flashback before you do the injection. As regards pregnancy, there's some people who have been given botulinum toxin and then they didn't know they were pregnant. I don't actually check the last menstrual period of my patients because most of them are not of menstrual age, of childbearing age. But I do make a note on my computer that if they're younger than, let's say, 60, I do ask them whether they might be pregnant. And I've always told my long-standing patients, please remind me if you are so that I don't have to keep asking you. But you do not want to inject a pregnant patient with botulinum because although it's been shown to be safe, there's no studies. Please don't forget, especially if your country has people with similar names, to check the identity, check and confirm injection schedules. I've had near misses where a nurse comes in, asks me a question, I go onto a computerized system, change the search, and then look at another patient. And then when I come back to the patient, I forget to change the injection. And that's where I do a personal timeout every time. And in fact, my instruction to nurses is do not disturb me while I'm doing my injections because I do not want it to be distracted. So check the injection schedule, do a timeout, check the identity of all your patients, and that is essential. I think the most important thing to me when doing injections is to manage expectations. Tell the patient, you're going to have this reaction, but for example, you might have weakness that will be exposed. In fact, because the injection will weaken other muscles, something else might come about. And in hemifacial spasm, don't forget things like muscle atrophy or even unmasking a synkinesis. I mean, I know this is a talk about spasticity, but it's the best kind of thing to explain to you what you want to tell the patient. So always manage expectations, document, do rating scales. And I like videotaping my patients before and after so that I always have a sense of how much they're doing. Rating scales don't always accurately reflect what the patient is like. And don't forget that each time the patient is different. I also ask my patients to do selfies, which I'll show you later on. Now, the next part will deal with injecting patients, which muscles, which technique, etc. And Dr. Ayub has already done a fantastic job talking a lot about this, but I do want to deal with it because this is about practical applications. So I think it's important to still go through some things. So when you assess the patient, think about assessing the patient as best as possible. Don't just, assume that there's certain muscles that are active therefore, or certain postures, therefore these muscles must be causing it, because the body is a complex organism. Often you will have more than one muscle causing problems. And don't forget, with spasticity, the problem is that there's weakness as well. And in fact, for those who've had surgery, it changes the anatomy completely. So the other thing is adequate exposure. Don't let your patients, even if your patients are shy, you can give them a modesty blanket or something, but expose them properly when you're doing the injection. Don't go through materials, etc. It just leads to problems. When I talk about observation, I also ask the patients, especially if they are not, if I have when I have a chaperone, which I usually do, I make sure that I watch all the muscles that might be relevant and keenly observe the patient. Don't just take their word for it. In fact, sometimes in my consults, there's not enough time to do everything I want to do. And I tell the patients, go back. You've seen the angles at which I videotaped you. Please get someone to videotape you and show me what you're like. And you'll be surprised at what you pick up each time. Observe the patient from different angles. Don't just look at an AP view, look at the lateral, look at the superior view. You will really pick up different things. And sometimes you need to observe posture and function in different settings. For example, now I'm going to hark back to dystonia. In cervical dystonia, when the patient's walking, that's when you pick up the cervical dystonia best. So for spasticity, see the patient doing what they want to do. Ask them, what is it that you really need help with? What are you not getting? What are you frustrated with? Because often they'll tell you something that surprises you, and that's when you need to help them the most. Okay, and of course, like I said, document as best you can. And this is a painting I've always loved. It's Rockwell's Golden Rule. And just as it says, do unto others as you would have them do unto you, I would tell you that my golden rules: do not impose your will on your patients. Ask, what do they need? What do they hope to achieve? What are their circumstances? And that includes even financial, etc. Because in different countries, we have things like insurance or government subsidies, but some patients have to pay for everything themselves. And the last thing you want is to make the patient pay a lot of money and have very little return on investment. So when you do the injection, I just want to quickly go through muscle, localization technique, dose, and dilution. This is the setup if you are doing EMG where you are actually just listening to the muscle. So for example, in cervical dystonia, I would use this. And the setup is almost like a normal EMG where you're listening for feedback and looking at the EMG activity. So although you're using a normal monopolar needle, all you need is an anode and your earth, and you're fine. So that's not difficult. When you're doing, this is actually also another form of just passive EMG, but in this case, you're actively contracting the muscles, so it's the same setup. When you're doing electrical motor points, electrical stimulation, you are basically using you're actually using the points when you deliver a motor NCS stimulation. So that's exactly how you do it. So again, always remember that with a monopolar needle, you actually need an anode, or you're not going to get that done. And this is the setup for ultrasound. So don't forget, as Dr. Ayub says, that you have different ways of doing it. So I'm quickly going to go through just some videos. This is a passive, this is an EMG where you're actually activating the muscle. Here, this man is having his medial rectus injected. You put the needle in, and then you're listening as well as looking for the activity. And when he activates the medial rectus by looking to his left, in this case, then you will get the sound that you're looking for, that lovely raindrops on a tin roof, and that tells you that you're in the right muscle. With electrical stimulation, I don't want to go through all the videos because it's about a minute long, but don't forget that I think that electrical stimulation is most important in the hand, the arms, and the legs. For everything else, I think you can get by without doing it. And in fact, there are times when electrical stimulation is not good, right? So you wouldn't want to do it for the eye or for spasmodic dysphonia injections. Here I'm trying to get EDC, and in fact I'm targeting only the middle finger. So you see that the advantage of electrical stimulation is that I can move the needle around until I get the muscle that I want. Am I in the right muscle bundle? So I do this for anything that is a complicated muscle, for example, the FDS, FDP, and FDL and FDB in the leg, for most of the hand muscles, because they're complex muscles, you want electrical stimulation, because if you do it with electrical monitoring activity, you might be moving the finger, but your adjacent fingers will also move, so you don't know which muscle bundle you're in. This is ultrasound guided injections. You see here, Dr. Ayub talked about needle in plane and out of plane. This is in plane, but you can actually see the needle and the injectate going in. And this is needle out of plane, where you just see the ghost of the needle position as it's going in. But again, you see the deformation of the muscles as the injectate is given. I need to thank Siddha Koser for this video. So very quickly, I just thought that, you know, I would liken injecting patients with botulinum toxin to somebody on a tightrope. You know, you as a doctor, you are balancing what the patient feels he or she needs versus what you yourself feel the patient needs. And often the patient just doesn't even want what you're hoping to achieve. And it's a discussion you have. Also, the patient might need more, but he or she can only afford a bit less, or only have a maximum dose allowed in one sitting, right? So you need to balance and decide what is of highest priority. And then we try to restore function, but sometimes the patient just wants injection for hygiene or for appearance. For example, the flexed arm in a spastic patient after hemiplegia. You don't think it's important, but they might be very bothered by it. And then, of course, you ask yourself, what's the best technique versus what are you able to do? What's your expertise, comfort, equipment? And for example, patient's comfort, because a patient who's pediatric age, who's injected for CP, might not be able to tolerate your electrical stimulation. And you would then want either ultrasound or something else, like even anatomical localization, because you want to fast in and fast out. So lastly, after the injection, what do? Don't forget to enlist the help of your rehab people. Rehab is very, very important. And I frequently, in fact, draw out charts for my patients. So companies like Allergan, Ipsen, etc., have all designed charts for patients to be given. But I find that often I just draw stick figures and tell the patient, look, this is what I've done. This is the muscle that I've injected, and this is what I'm hoping the injection will do for you, and these are the exercises you do. Or now I even ask them to videotape my hand or my leg as I do certain exercises for them. But you realize that we're all busy, and especially during COVID when patients could not come, and now as they're able to come back to hospital, my clinic is overflowing, and I find that it's really hard to find the time I need to discuss it with things with my patients. So anyway, I always ask them to send me video selfies. I tell them, if you can't do it, ask someone else to videotape you so that I can see how you're doing in 3 weeks' time. And then we can discuss, because sometimes if they come back for the next injection, you don't know how they've done. And their perception of how they've done is different from the reality. So I think this is my last slide. Jean-Michel has worked with some of the folks in Korea, and as have other people. For example, Prof. Kaji has also done work on electrical stimulation after botulinum toxin injections. And although not all the studies are positive, there is thought that electrical stimulation after injection of botulinum toxin has benefit. So in this study of 15 patients, Jean-Michel and Jongmin Lee showed that there was benefit. So actually that's the end of my slide. Thank you very much. And well, I encourage you to come to Singapore at some point. It's hot and humid here, but well, every place is interesting. This is our cyclonic fountain at the Jewel, which is in our airport. So even if you're stopping over, just walk over to the airport, see this, and then go back on your next flight. Thank you so much, and take care, everyone.
Well, thank you so much, Dr. Lim. That was wonderful. You know, it's not every day you get a medical presentation with Norman Rockwell bartending mise en scène.
I love paintings, and I love narrative storytelling because it allows me to change my stories as I go.
Great. I don't see Let me see if there's any question. I don't see any questions, so we should wait for a couple of minutes and then see. Is there anything while we're waiting? Is there anything that you, Dr. Ayub, and Dr. Lim would like to add to the presentations?
Well, I'm hoping for the questions, if anyone has questions, happy to take them and have some discussion, and would love to hear some questions, exchange. I think it's always educational when you give this presentation. You learn some as well from these questions.
Well, there's a question, and that is, how do you perform the stim? Any tip for that?
Yeah, I mean, I can take that. It's simple, you know, a lot of these electrical stimulation machine available in a small size, portable size, has a 3 ports. One port for your reference electrode will serve. The second port will serve as ground. And the third one will be your active electrode, where you hook the needle and the needle itself has injectable port. And Dr. Lim showed that in his slide. And some of these portable machines, small like this, I'm not promoting any brand, and this is give you both actually EMG and nerve stimulator mode, and you can, and has a little screen you can watch actually the muscle activity when you do EMG. Yeah, once I like to hook the needle to a small extension tube that give me more flexibility, so I don't have a long syringe to maneuver, and someone who has deformity and contracture, that give me more that maneuverability. You know, once you find the needle, it's important when you aspirate, you don't move your needle. You always want to have this muscle contraction as you inject. Some may lose that because, you know, you're paying attention on the needle and you forget, well, no longer your needle stimulating the muscle, or you're already outside the muscle. And sometimes it takes really just a small, tiny movement, right, left, south, north, deeper, or superficial to lose the muscle, the targeted muscles. So you really want to be attentive while you're injecting. You should have this muscle contraction.
Yeah, so I'll add to that, which is that the amperage when you're delivering the stimulation, I usually use something between 5 and 6.5. I try not to go past 6.5 because you realize that there's volume conduction of the electricity as well. And if you if you give a very high dose, you tend to stimulate nearby muscle bundles, and so that is a problem for me. It's also painful for the patient. Yeah, I sometimes do a repeated stimulation because, as Dr. Ayub says, it's easy to move the needle out. So if the patient can tolerate it, I do a very low current, like 5.5 milliamperes, and I do a 1 per second stimulation. So you can set your machine for that, and because it's distracting as you're trying to find the muscle, etc., to also have to keep pressing the button to deliver the current. So I just set it for 1 per second, and then I get to see the muscle and make sure it's still twitching. But there are people who can't tolerate it. And so for those, I might consider ultrasound. But I'll tell you that the trouble with ultrasound, if you see muscles, if you go and look at a muscle atlas, or if you look at this paper by Aymeric Lim in, I think it's in Han. I'll send the link to Tran. But he used Sealer's technique to look at muscles after dissection. And you'll find that the tendons of your, let's say your flexor, your FDS, your flexor digitorum superficialis or profundus, you can't quite see where they split up from the origin and very proximally. And if you think that one nerve is supplying multiple muscles, right? You might have individual digital nerves, but that one nerve is supplying your muscles. So it's very complex. The hand muscles are so complex that I find that electrical stimulation is the way to go, because then you're only stimulating the muscle bundle. But I would say that in addition to all the other practical tips that I put down, don't forget your EMG needle, even your monopolar concentric needle has different sizes. So if it's a tiny muscle, I go with a tiny needle. But of course, it's expensive, so you don't want like 10 needles to inject. I will find the best fit for the patient, and then I make sure it's long enough to hit the target muscles. The setup of your EMG kit, you can find it in any book. And if you have not been doing it before, I suggest finding someone who does it. Go for courses where they teach you. Unfortunately, many courses only do it with a dummy, and that's not satisfactory to me. I hate teaching on a dummy because it's never accurate. Uh, don't forget that we're all so far removed from our anatomy lessons that there's no harm and no shame in opening up a textbook. So, I now have been looking at 3D images of muscles, etc., to revise all the time. And I think I've never ashamed to tell people I need someone to come in with me. So although I know how to do muscle ultrasound EMGs, I find that I'm so bad at it that I stick to EMG, which is what I'm good at. Ultrasound I'll do if someone needs something complex. So for example, in cervical dystonia, for the OCI, I always use ultrasound because you can hit a vertebral artery or a basilar artery. You don't want that, right? Sorry, the vertebral artery or the spinal artery. And the same goes with scalene, where you can hit the brachial plexus. So ultrasound has a very important place, but I would argue that electrical stimulation also has a very important place, especially in the forearm and in the EDB, EDL, FDL, FDB. These are muscles where if you're talking about individual toe function, you need something to see. So I'm letting Dr. Ayub continue. Sorry, I took quite a
No,
long.
I'm glad you made these additional remarks. I totally agree with what you just stated. To me, is ultrasound is more anatomical tool, structural localization, and I want to see more than a structure. I want that electrophysiological response to my stimulation, where your toxin gonna be worked. So for spasticity, upper and lower limb, there are exceptions for some muscles, maybe ultrasound more useful, difficult, very deep. As I said earlier, iliopsoas muscle, by the way, in US, it's not FDA approved injection for toxin, iliopsoas muscle. But again, as a guidance technique to do any injection in that muscle, I would use ultrasound. I can see the value of ultrasound. Otherwise, I really look for that physiological response for my stimulation, and that's the best confirmation my needle in the right place.
I would also add as a final point that don't forget that things change as time goes by. So for example, as muscles atrophy, other muscles might now become more active and cause a different position. So as that slide, the Rockwell slide says, don't do unto others as you would not, do unto others as you'd have them do unto you. Just remember that your poor patient has no knowledge of what you're doing. They trust you. And so we have this job to do the best we can by them. So I find that muscle injections can be harder as time goes by because they shrink. And worse still, sometimes the disease changes, especially in dystonia. And so every injection for me is a new injection. I always rethink, what do I do now? And I think that for me has been the most interesting thing about injecting botulinum toxin, that we look at every injection.
Absolutely. I mean, I've been doing this 25 years. As I said, this morning I had 14 injection in 3 hours, right? And sometimes it can be challenging. I have even a big muscle as biceps and pecs that I may have injected 20,000 times already in the past. It takes you a few attempts to really find the injection. My residents, if anyone on the call can see that, it can happen due to muscle atrophy, changes in the muscle, as you stated. So it's always use guidance to really, if you want to be accurate. Sure, in some superficial muscle in well-developed person who had low fat percentage, you can see probably their superficial muscles through the skin. You can do that with a manual, probably needle placement. But always I tell everyone, even I do it manually without guidance occasionally in some patients, but I always select who I can do it with confidence because I want to be accurate, like at least 95% if I do it. And patients that have been injecting over 20 years, they definitely have muscle atrophy. People have a lot of adipose tissue, thick arm, leg. That's when I use really needle. And also the first time I inject, if it's the first time the patient injected, I want to get the best outcome from the first injection because I don't want the patient to not show up again because there is no benefit. And I don't want localization to be the reason for lack of response for the treatment. So that's not in my differential list when I do guided stimulation E-stim in this patient. Again, this is we're talking about the spasticity E-stim. There are other values, other areas, other regions, cervical dystonia, neck, we inject other region, but I strongly feel about E-stim for upper and lower limb injection in spasticity.
Sorry, so teacher, I saw there's a question, but before that, a point I didn't make because I only, I thought with 20 minutes I should not bring other things in, but with contractures, don't forget that once someone has contractured, there's no point giving botulinum toxin anymore. And in fact, I don't know Dr. Ayub agrees with me, but I find that I can stave off contractures with botulinum toxin because if you inject them regularly, they don't have the chance to develop contractures, or at least you delay it. So, I use ultrasound also to see if there are contractures in the muscles, because if that's the case, I just tell them, look, go for surgery or do something else, but don't, botulinum toxin is not going to help you. And to answer the question in the chat, no, the only thing that I've noticed with COVID is that my patients seem to be less stressed because they don't go out, they're not seen, they're not judged. So they're quite happy not to get injected. And in fact, for the spastic patients, I have to tell them, no, come back, because whatever it is, I'm trying to help you with some things. So I can draw the botulinum toxin injections out longer. Certainly for hemifacials, which I do mostly because Asians have a lot of hemifacial spasm, I find that they can drag the injections out as well because they're wearing masks, they don't care so much about it. So in relation to COVID, other than being more comfortable, more relaxed, which does affect, movement disorders, spasticity, I haven't noticed anything, but I think we've had only we don't have that many patients with COVID in Singapore. We had a whole bunch for a while, and then we're back to almost single-digit numbers now. So in relation to COVID patients, I haven't seen in anything, but in relation to the phenomenon of COVID, I think my patients are more relaxed, less anxious, and generally doing better. Dr. Ayub, sorry.
Yeah, no, that's okay. I mean, the question probably I can read it two different ways. Injection of toxin in patient who has had COVID and that type of thing, if they had a stroke and other stuff, or how COVID, the pandemic, affected the patients who are being treated in our facilities or practices for spasticity. Yeah, it depends perhaps on the region. In my area, we at one point we had to close the clinic because of the surge and shifting resources to inpatient. So for about 6 weeks, starting in December, I had to shut down my clinic, but we reopened and patients are coming back. As I said, like this week I have 15, last week in my clinic was another 14 or 15 patients. And, during COVID, a lot of patients actually would call, I don't care about COVID. I want to come see you. I want to come to the clinic. Few patients may have been hesitant. They they're afraid to come to their follow-up. And you have people in between who understood the emergency, and now the clinic closed. I have to wait for the clinic to reopen to come back. But we still have COVID big time in LA County. I'm in Los Angeles. We're still dealing with this crisis. And like patients showing up, almost 100% show rate in my clinic, even with COVID time.
I think that's all the time we have for today. And thank you again, Dr. Ayub and Dr. Lim, for your wonderful presentations. And as a reminder that their presentations will be available online on demand at www.iaprd.org. And so goodbye for now, and hope you will join us again at our next webinar. Thank you and bye-bye.
Thank you.
Stay safe, everyone. Bye-bye.
Bye-bye.
Bye, Dr. Lim. Bye-bye, Ditran. Thank
Bye.
you. Bye.
Goodbye.
A pleasure. Take care.
Bye, Marianne.
Marianne.